We are continuing on with our respiratory emergencies. I wanted to take a break that way that you guys could also take a break before starting the next slideshow. So let's continue on with other causes of respiratory distress. Pneumonia is primarily an acute infectious disease, bacterial or viral, affecting lower respiratory tract with inflammation in fluid or pus-filled alveoli. It can also come from toxic inhalation or aspiration. In your assessment, you may see malaise, decreased appetite, fever, may be absent in the elderly, cough, dyspnea, tachypnea, tachycardia, chest pain, decreased chest wall movement, shallow respirations, splinting, crackles and bronchi, altered mental status, diaphoresis, cyanosis, pulse ox less than 94%. Emergency care is supportive and follows your general respiratory distress approach. All right, pulmonary embolism. Think risk factors: immobility, heart disease, recent surgery, long bone fracture, pregnancy, cancer, DVT, estrogen therapy, and smokers. The pathophysiology includes sudden blockage of blood flow through pulmonary artery or branch. This could be a clot, air, fat, a foreign body, amniotic fluid, leading to decreased gas exchange and hypoxia. Now onto your assessment. Sudden or explained dyspnea, sharp stabbing chest pain, cough, tachypnea, tachycardia, syncope, cool, moist skin, anxiety, sense of doom, late hypotension, late cyanosis, late distended neck veins, possible crackles, possible fever, pulse ox less than 94. Not all signs are always present. Your emergency care should include airway, oxygenation, PPV if needed, early oxygen, and monitor for arrest and immediate transport. Now, acute pulmonary edema. This is cardiogenic and non-cardiogenic. Cardiogenic is heart pump failure, increasing pulmonary capillary pressure and forcing fluid into the interstitial spaces in alveoli. Non-cardiogenic is often called ARDS. It comes from capillary bed destruction with fluid leakage after severe illness or injury. Now your assessment. Dyspnea, especially on exertion, orthopnea, frothy sputum, tachycardia, anxiety, confusion, tripod with legs dangling, fatigue, crackles and maybe wheezing, cyanosis, pale moist skin, JVD, swollen lower extremities, cough, possible fever, signs of cardiac compromise, and pulse ox less than 94. Now, in your emergency care, PPV if inadequate breathing. CPAP can be extremely beneficial in distress or early failure if allowed. If breathing is adequate, administer oxygen and maintain a pulse ox of 94 or greater, upright position, and rapid transport. All right, SCAPE, sympathetic crashing acute pulmonary edema. It's also called flash pulmonary edema, hypertensive acute heart failure. Pathophysiology includes sudden increase in sympathetic output, causing systemic vasoconstriction and shunting blood to core, leading to severe hypertension and increased afterload. The ventricle struggles, pulmonary pressures rise, fluid shifts into interstitial and alveolar spaces, diffusion becomes impaired, and you get profound hypoxemia and hypercapnia. Assessment. Rapid onset distress, tachypnea, dyspnea, profound hypoxemia often below 90, severe hypertension commonly over 160 and sometimes over 200 systolic, diffuse crackles, peak frothy sputum, pale, cool diaphoretic skin, tachycardia, agitation, history of recurring episodes. Triggers include chronic left ventricle failure, hypertension, medication non-adherence, volume overload, sympathetic, this is a big word, sympathomimic exposure, withdrawal from certain meds, acute MI, exertion, stress, and anxiety. Emergency care focuses on improving oxygenation and decreasing blood pressure. CPAP is highly recommended if allowed, starting around 5 and titrating up per protocol. Nitroglycerin is often used in ALS settings to reduce vasoconstriction and preload or afterload. Follow your protocol and medical direction and arrange for ALS intercept. Spontaneous pneumothorax. Visceral pleura ruptures without trauma. Air enters the pleural cavity, lung collapses, gas exchange is impaired. Primary occurs in tall, thin teens to early 20s with no underlying disease, secondary to COPD or connective tissue disorders. Your assessment: sudden shortness of breath, sudden sharp chest or shoulder pain, decreased breath sounds on one side, subcutaneous emphysema, tachypnea. Let me try that again. So, decreased breath sounds on one side, sudden sharp chest or shoulder pain, subcutaneous emphysema, tachypnea, diaphoresis, pallor, late cyanosis, pulse ox less than 94. Now your emergency care. Oxygen to maintain a pulse ox of 94 or greater if distress or chest pain indicators exist. PPV if inadequate, but be careful not to create a tension pneumothorax. CPAP is contraindicated in these situations. Suspect tension pneumothorax with cyanosis, hypotension, significant resistance to ventilation, and severe decline in pulse ox. Contact ALS immediately. Hyperventilation syndrome. This can be an emotional or can mimic serious medical issues. The pathophysiology is anxious patients feel like they can't catch their breath, blow off CO2 by breathing fast and deep. Signs include fatigue, anxiety, dizziness, shortness of breath, chest tightness, tingling around the mouth, hands, feet, tachypnea, tachycardia, spasms, possibly seizures and seizure disorders. Now, emergency care with these patients. Calm the patient, slow breathing, breathe through the nose, remove anxiety, the anxiety source. Do not have the patient breathe into a paper bag or a non-oxygen mask. Use CO2 rebreathing only if no underlying medical conditions and specifically directed by medical direction. Apply pulse ox and verify oxygenation because you do not get to assume it's just anxiety. Now, epiglottitis. Epiglottitis and surrounding structures inflame and swell. Let me try that again. I should have took a longer break. Epiglottitis. The epiglottis and surrounding structures inflame and swell, compromising airway. Historically, HIB in kids, now more adult prevalence, but still deadly. Signs: URI for a day or two prior, dyspnea with rapid onset, high fever, sore throat, drooling, anxiety, tripod with jaw forward, fatigue, high-pitched inspiratory stridor, cyanosis, trouble speaking, and pulse ox less than 94. Now your emergency care. Maintain oxygenation to 94 or greater. Calm, quiet environment. Position of comfort, rapid transport. ALS intercept if possible. Do not force Airway inspection if the patient is moving air, because agitation can worsen swelling or occlude the airway. Airway maneuvers only in extreme cases. If BVM is ineffective, ALS may need to consider advanced options. Pertussis. This is a contagious bacterial disease spread by droplets. Younger patients often worse. Starts like a cold, then coughing fits into a whoop. Complications including pneumonia, dehydration, seizures, brain injuries, and death. Signs: a URI history, sneezing, runny nose, low-grade fever, malaise, worsening cough, nighttime cough fits, vomiting, inspiratory whoop, cyanosis during coughing, falling pulse ox, exhaustion, trouble speaking, and breathing during fits. Now your emergency care. Position of comfort. Oxygen if pulse ox is less than 94 or distress, via nasal cannula, titrated up to 94 or greater. Encourage expectoration. Calm environment. Rapid transport. Consider ALS. Take precautions for cross-contamination. Cystic fibrosis. This is a hereditary disease with thick, sticky mucus, recurrent infections, progressive respiratory failure, GI issues. Assessment. Known history, recurrent cough, thick mucus, recurrent pneumonia, bronchitis, sinusitis, GI complaints like greasy stools, abdominal gas pain, malnutrition, dehydration, clubbing, trouble speaking or breathing with mucus buildup. Emergency care is symptomatic. Oxygen to maintain at 94% or greater if needed. Consider normal saline nebulization if protocols allow to thin out the secretions. Position of comfort, ongoing monitoring, ALS rendezvous if serious. Now let's move on to poisonous exposures and inhalation injuries. These are common after fires. Inhaled poisons include carbon monoxide, chlorine, ammonia, industrial gases, smoke, solvents, and many more. These can cause cellular hypoxia, upper airway swelling, displacement of oxygen in alveoli, alveolar damage, and death. In your assessment, history of inhalation injury, chemicals on face, distress, cough, stridor, wheezing, crackles, oral burns, hoarseness, dizziness, headache, confusion, seizures, cyanosis, nausea and vomiting, copious secretions, and abnormal vital signs. Emergency care. Limit exposure. Scene safety first. Ensure open airway. Position of comfort if alert and non-trauma. Supine if trauma and unresponsive. Oxygen is to keep the pulse ox 94 or higher, or PPV with oxygen if inadequate. Treat other injuries. Gather information for receiving facility. Arrange for ALS intercept. Viral respiratory infections. This is another little category. URIs, but in kids can involve lower airway. Viruses include rhinovirus, influenza, RSV, adenovirus, and etc. Signs include congestion, sore throat, mild distress, cough, fever, malaise, headache, body aches, irritability, and poor feeding in infants, tachypnea, asthma exacerbation. So your emergency care in all of these. Supportive. Positioning is key. Oxygen therapy as needed. Emotional support. Gentle transport. If poor perfusion or shock signs or pulse ox is below 94 at baseline or any time, give oxygen. Your nasal cannula often starts around 2 liters per minute and titrates up until the pulse ox reaches 94. If nasal cannula is at 6 liters and doesn't achieve the target, consider a non-rebreather mask if appropriate. Some systems used high-flow therapies during COVID. Follow your local protocol. Now pause and think. How important is it to determine the exact cause? It matters, but not more than oxygenation. If you chase a diagnosis while the patient deteriorates, you lose. Support breathing first, then refine the cause later. All right, MDIs and small volume nebulizers. Many patients with chronic breathing problems are prescribed beta-2 bronchodilators through a metered dose inhaler or small volume nebulizer. Medication is dispensed as a mist and deposited directly into the lungs. An MDI is an inhaler or puffer, as has a metal canister or a plastic container. When depressed, it delivers a precise dose. Some MDIs use spacers or valved holding chambers to improve delivery. If breathing difficulty is not related to trauma or chest injury, contact medical direction or follow protocol for assisting with prescribed medication. Even if the patient says they know how to use it, you should coach them. Slow deep inhale, hold breath as tolerated, slow exhale through pursed lips. If they can't do it, you may need to assist with the process. Small volume nebulizers use liquid medication placed in a reservoir. It's attached to a compressor that delivers compressed air or oxygen by tubing. The patient inhales the mist through the mouthpiece or mask until it stops. Indications, coaching, and assessment are similar to MDI. If oxygen was used as a driving gas, flow is often set around 8 to 10 liters per minute per common teaching, but follow your equipment and protocol. Advair is a maintenance medication for uncontrolled asthma and includes a long-acting beta-2 drug plus a steroid. It's not a rescue inhaler for an acute attack. Some inhaled medications aren't appropriate as rescue meds because onset is slow and the purpose is long-term control, not immediate bronchial dilation.